So I think we'll get started with our next session. We have an impressive line of speakers for our next session. The first talk is titled The Perioperative Use of Methadone. And I think methadone is not very much used by a lot of anesthesiologists in the perioperative arena. And who better to give this talk than Dr. Evan Karash? Most of you know Dr. Karash as the past editor of the prestigious journal Anesthesiology. He serves as the Merrill Hermel Distinguished Professor of Anesthesiology at Duke University, and he is also the department's Vice Chair for Innovation. He also serves as the Director of Academic Entrepreneurship for the whole medical school, which is a huge responsibility. He's also an expert in the pharmacology of anesthetic and pain medications, and all of his research is centered around the basic and clinical pharmacology, including drug disposition, pharmacodynamics, as well as pharmacogenetics, which is huge in this current times, and also drug safety. And I really, really grateful for Dr. Karash to be here today with us, considering he's so busy with all his other responsibilities down at Duke. And thank you very much. And his flight was delayed by 3 hours, so we really appreciate that.
Thank you very much. That was a very kind invitation, and I really appreciate the opportunity to speak at this meeting. And it's always fun to see old friends, make new friends. And I learn a lot from these kinds of presentations, so please do ask lots of questions at the end. I want to talk about methadone today, and this is it is not a new drug, but it's a new way of thinking about providing intraoperative and postoperative analgesia. So let's start with a hypothetical case. A representative of a local drug company comes to you and says, I have a new drug product. It's a new analgesic. You only have to give one dose of it at the induction of anesthesia. Your entire anesthetic is a simple 2-drug approach. This new drug does it all, and then keep your patient asleep with an inhaled agent or propofol. You don't need any other opioids during the course of the anesthetic. Postoperatively, the patients will statistically have about 30 to 40% less pain than if you had done the case with fentanyl. They'll use 30 to 40% less opioid than if you had done the case with fentanyl. Patient satisfaction scores will be much higher. There may be a follow-on effect where these patients have less pain postoperatively for weeks or months after surgery, and the whole thing's about $20 a dose. Is anybody interested? Okay. So to start with, disclosures, I serve on a data safety monitoring board for a local pharmaceutical company, but I do have some bias. I have a great bias. Over the course of the 4 decades that I've been involved in providing anesthesia in the operating room, there's been a tremendous shift in the specialty. We've shifted from balanced anesthesia to now what some people have called an anti-opioid hysteria. And as I've written about on several occasions, I think it's appropriate that we shift that balance back a little bit more towards rational opioid use, the appropriate treatment of perioperative pain, and more use of balanced or multimodal anesthesia. So I'm going to cover some information. I will tell you that there's more information in my slides than there is, and I will speak because I like to provide something that's a little bit of a reference for you when you leave here. I know when I go to meetings, by the end of the first day, I'm pretty saturated. I'll look back and think, what was it that was said that accompanied those slides? So I give you a lot of information that you can use as reference. I want to cover 3 things. I want to talk about the basic pharmacology of methadone, talk a little bit about the pharmacokinetics and the clinical effects, and then how do we practically use the drug in the perioperative period? And I'll couch this in the frame of we have 3 big jobs or 3 major problems. One is providing appropriate intraoperative and postoperative analgesia. The other is avoiding avoiding postoperative opioid-induced respiratory depression. And then the other is the opioid crisis and how that has markedly changed the entire perioperative ecosystem and the atmospherics around intraoperative anesthesia care and delivery. And of course, this is all couched in the perspective of appropriately treating pain. First challenge is providing adequate perioperative analgesia. We all like to think that we're doing a fantastic job. There's a survey that's done about every 10 years asking patients about their perioperative experience. The vast majority of them will report that actually they did have acute postoperative pain, and the majority of them say that it was moderate to severe. Less than half of patients surveyed say that their pain was adequately treated postoperatively, and there's been no meaningful progress in any of this over the course of the past several decades. So we think we're doing a wonderful job, and patients don't agree with us. The other problem is chronic post-surgical pain that affects 10 to 80% of patients. On average, it's said to be about 20 to 25%. That is an astoundingly high number of patients who come to the operating room expecting to have their operation fix whatever it is that is ailing them, and a quarter of them will leave with pain that they didn't have before. We know that acute postoperative pain is the single biggest risk factor for chronic post-surgical pain, and that inadequately treated pain affects patient recovery and the quality of life. Acute postoperative pain, as I said, is common. We like to think that laparoscopic procedures hurt less than open procedures, and that's not really true. It's not just an incision that causes pain. We know that acute postoperative pain is associated with surgical complications like surgical site infections, urinary tract infections, ED visits, and readmissions, and it's associated with general complications such as postoperative delirium. Chronic post-op pain that lasts more than 3 months, is tough to control, it's tough to treat. The single biggest risk factor for chronic post-surgical pain is acute postoperative pain, so we need to focus on treating acute postoperative pain. And for every 10% increase in the time that a patient is in acute postoperative pain, there's a 30% increase in the risk of chronic post-surgical pain. Second problem we have to deal with is opioid-induced respiratory depression. The Anesthesia Patient Safety Foundation says that no patient should be harmed by opioid-induced respiratory depression, and I don't think that anybody would disagree with that, but it still happens. The incidence of severe postoperative pain due to opioids is a fatality incidence of about 1 in 75,000 cases. Most of us may work at hospitals that do more than 75,000 surgical procedures a year, and the incidence of what we call clean kills on the wards is 1, 2, or 3 patients per year, and this is unacceptable. The single biggest risk factor or risk period for acute opioid-induced respiratory depression is the first 24 hours postoperatively, or the window of vulnerability. And then, of course, the third problem is the opioid crisis. The opioid crisis has absolutely nothing to do with the operating room, period. The opioid crisis translates back to the inappropriate overuse of oral opioids by primary care practitioners for patients in whom they were not indicated and not effective. We fast forward a couple of decades, and now the opioid crisis is actually a fentanyl crisis. 90% of the opioid-related fatalities are due to illicit fentanyl. None of this has to do with the operating room. The only data point that is material is that we do know that surgeons overprescribe oral take-home opioids where they're statistically only used for 2 to 3 days. The remainder sits in a medicine cabinet when they're not appropriately stored, and they are susceptible to misuse or diversion. I think our goal in the perioperative period is not to react to the opioid crisis in strange and unusual ways, but rather to use opioids logically, rationally, and to devise anesthetic regimens which optimize postoperative analgesia and perhaps even decrease the need for postoperative opioids. So what we do in the operating room is relatively simple. We just have to do 4 things. manage autonomic responses, provide anti-nociception or treat pain, make sure patients don't move, and make sure that they are unconscious or don't remember their surgical experience. Now, if we move into the postoperative period, very often we simply tend to think of the finish line for anesthesia as being the entrance to the PACU. I moved to a new institution where the attending anesthesiologist had to go to the PACU to discharge a patient, which I thought was a little bit unusual because I had never done that in any of my previous institutions. We all had standing orders for nurse discharge from the PACU, but I now start to see and appreciate all of the problems and all of the untreated pain in the PACU. So our job doesn't stop at the entrance to the PACU. Hospitals think that the finish line is the exit to the hospital. But what you can appreciate is that pain continues throughout this entire period. All of the other things that we need to do stop at the entrance to the PACU. Pain doesn't stop. So I think our goal should be to optimize analgesia throughout the perioperative period. And as I look at the 40 years that I've been involved in giving anesthesia, there's been a steady trend to shorter and shorter and shorter duration opioids. Fentanyl to sufentanil to L-fentanyl to remifentanil. But those figures that patients are telling us about the amount of pain that they have and the untreated nature of their pain hasn't changed. The shift to shorter and shorter duration opioids hasn't fixed the problem of perioperative and postoperative pain. So what do? How do we provide adequate intraoperative and postoperative analgesia while minimizing the chance of opioid-induced respiratory depression? If I'm doing that, I want two characteristics of a drug. I want rapid onset and duration of effect that matches the duration of pain. To do that, we simply have to get a drug concentration above the minimal effective analgesic threshold and to maintain that there as long as possible. Now, to look at this in terms of a cartoon, this is blood or effect site concentrations over the course of time. And what you see is that with most of the standard analgesics and opioids that we have, concentrations cycle up and down. Ideally, we want to be in the therapeutic window or that green zone of analgesia. Concentrations drop below it into the yellow zone. Patients are going to experience pain. And if we overshoot into the red zone, we risk respiratory depression. And for every modality, whether it's oral opioids, whether it's intermittent PCA, whether it's intermittent operating room opioid dosing, we are cycling up and down. The only exception is a remifentanil infusion, but the instant that we turn off that remifentanil infusion, plasma concentrations drop, and of course the risk is that patients wake up in pain. The one exception to this is methadone. Methadone, because of its very long elimination half-life, achieves and maintains that therapeutic concentration at a relative steady state. If we compare the opioids that we have available, we can compare them in terms of their onset speed, or what we call the T1/2 KE0, that kinetic constant for the time for drug to get from blood to effect site. We've got ultra-fast onset opioids like remifentanil and L-fentanyl, the fast onset like fentanyl, sufentanil, and methadone, very slow onset drugs like hydromorphone and particularly morphine. Elimination half-life ranges from very short or ultra short for remifentanil, up to 2 to 3 hours for morphine and hydromorphone, 8 to 10 hours for fentanyl and sufentanil, and 1 to 2 days for methadone. So if we're looking for a drug with a fast onset and a long duration of action, methadone meets those criteria, and it's the only drug which does. So to revisit very quickly, methadone's a mu receptor agonist, a very classical mu receptor agonist. It may also have some influence at the NMDA receptor, the serotonin reuptake inhibitors. It's a very useful drug. You can give it by a whole variety of routes of administration. We use it in age ranges ranging from neonates all the way up to geriatrics. It's extensively metabolized. The metabolites are inactive. There's some differences between R and S-methadone. The vast majority of the opioid effect is due to R-methadone, not S-methadone. And the half-life, as I said, is long. it's 1 to 2 days, and there's incomplete cross-tolerance with other opioids. So patients who are on chronic opioids, who you would expect to have a higher fentanyl requirement, for example, do not have a higher methadone dose requirement, which makes dosing much more simplified. So to go back to the cartoon, this is what the world looks like in the world of methadone, where now the x-axis has changed from hours to days. A single dose leaves you in that therapeutic window for 1 to 2 days. The higher your dose, the longer you stay in that therapeutic window, and it's because of the slow elimination rate, which gives you a very long duration of effect. Now, the paradigm change, if you will, is that using methadone, a long-duration opioid, tells us that a single intraoperative dose of methadone, which is going to sustain and maintain therapeutic drug concentrations for a long period of time, is going to be more effective than multiple doses of short-duration opioids. The other issue is that once we achieve and maintain that therapeutic methadone concentration, patients are going to need less postoperative opioid. Because they need less postoperative opioid, the risk of postoperative opioid-induced respiratory depression is diminished. And this is particularly true in that 24-hour window of vulnerability. Now, several years ago, 2011, I published an editorial, sort of a mini review in Anesthesia and Analgesia, said it was time to rediscover, reappraise, and reinvigorate the use of methadone in the perioperative period. Things change slowly, but the use of methadone is increasing over the course of time as we've begun to recognize the fact that we're not doing as good a job as we should or would like to be doing in terms of treating perioperative pain. I also talked about some common misperceptions, that the drug has slow onset, that the duration of analgesia is shorter than the half-life, and that there's a risk of postoperative respiratory depression, and hopefully I will convince you that that's old information, which is not correct. The first reported use of methadone in the perioperative period, as far as I can tell, was reported by Gourlay and a group of investigators in Australia. This was back in the 1980s. They took an undifferentiated group of patients having inpatient surgery. They gave some methadone, they gave some other opioids. The patients that got intraoperative methadone, only 1/3 needed additional parenteral opioid during the course of their hospital experience. 1/3 went to oral opioids, and 1/3 went home without needing any more opioid whatsoever. These patients had significantly lower post-op opioid requirements. Despite the fact that they all had unlimited access to PCA, they had much lower pain scores, and there was no difference in side effects in terms of patients who got methadone or other opioids. A more recent study that was done a few years ago at a private hospital outside of Chicago by Glenn Murphy, he looked at methadone for major spine surgery. He looked at analgesia, opioid requirements, and patient satisfaction. On the left, you see patient pain scores, and he compared hydromorphone to methadone. The hydromorphone group is in blue, the methadone group is in red, and what you can see is that whether it was pain at rest or pain with movement, pain scores were a lot lower in the patients who got methadone compared to the patients who got hydromorphone. Analgesic requirements, postoperative opioid use, was a lot less in the patients who received a single dose of methadone compared to the patients who received hydromorphone, and the patient satisfaction scores were actually higher in the patients who got methadone compared to the patients who received hydromorphone. So their take-home message was patients who got methadone had lower pain scores at rest, lower pain scores with movement and with coughing. Postoperative opioid use was a lot less in the patients who received methadone compared to hydromorphone, and that patient satisfaction was higher. And there was no difference in the incidence of postoperative adverse events or side effects in the methadone group compared to the hydromorphone group. That group did the same study in coronary artery bypass grafting in patients undergoing cardiopulmonary bypass. Same kind of design, compare intraoperative methadone. Now they compared it to intraoperative fentanyl. And again, they looked at analgesia, analgesic requirements, and patient satisfaction. The patients who received methadone compared to fentanyl had lower postoperative pain scores, they used less postoperative analgesics, and the patient satisfaction scores were higher. So again, the conclusion was that postoperative pain was 30 to 40% less, postoperative opioid use was about 40% less, patients were happier with their anesthetic, and there was no difference in opioid-related or general side effects in the group that got methadone compared to the group that got fentanyl. Now, over the course of the past several years, there have been a number of retrospective studies, meta-analyses, and reviews that have looked at perioperative methadone. They've tended to look at pain and opioid use and patient satisfaction. And the take-home message is that these studies, on average, show that patients have lower pain scores if they get methadone compared to a different opioid. Their postoperative opioid use is less, and the satisfaction scores are higher, all while there is no difference in the incidence between methadone or other opioids in the frequency of opioid-related or generalized side effects. Now, for many years, I used to talk about the use of methadone. People would ask me, do I use it in outpatients? Because of the increasing frequency of outpatient surgery. And I said, no, I don't, because there's no data. And after a while, I said, well, clearly we need to get the data. So I did 2 randomized, double-blind, placebo-controlled trials, or not placebo, but regular opioid use trials comparing methadone to other opioids for outpatient surgery. And we did this in 2 cohorts. We did it in a cohort of same-day discharge surgery, and then we also did it in a cohort of next-day discharge surgery. Now, we didn't know what the dose of methadone would be in these patient populations. The inpatient studies, we used 20 milligrams, but this dose requirement might be less in less invasive outpatient procedures. So we did what we called dose escalation studies, where we started with a methadone dose that we thought would be too low, and every group of 20 patients or so, we increased the dose of methadone until we got to what we thought would be the right dose of methadone. We dosed to ideal body weight so that we got around the issue of morbid obesity. When I moved from Seattle to the Midwest, everybody changed from being a fit marathon runner to not being a fit marathon runner. And I was introduced to things like double-wide wheelchairs and operating room tables that were stressed for 1,500 pounds. So that's when we switched to ideal body weight dosing. And the beauty of ideal body weight dosing is that, for the most part, everybody has the same ideal body weight. Adult females is 60 kilos, adult males is 70 kilos. I'm still trying to get to the ideal body weight for me. In this particular same-day discharge cohort, the vast majority of patients were female, just because that's what the population was. Cases ran about an hour and a half, and they were mainly things like lap choles and tubal ligations. Some results very quickly. We didn't tell the practitioners anything other than patients got randomized to methadone or do what you normally do. So the first question we wanted to know is, well, how much intra-op opioid you got used? So the graph on the left shows the big black bar this is the group of do what you normally do. The next 2 bars were patients that got methadone, and how much additional intraoperative opioid did patients need? And the answer is pretty much none. Single dose, intraoperative methadone, that's the only opioid. PACU opioid requirements are shown in the 2 panels on the right. The middle panel is PACU opioid, and the panel on the right is how many patients needed no PACU opioid at all. And what you can see is that at the dose of 0.15 mg per kilo, or about 9 to 10 milligrams of intraoperative methadone, patients really didn't need any opioid in the PACU. 60% needed no additional opioid before they left the PACU. On the left is the total day of surgery opioid that patients received, and you can see at the 0.15 mg per kilo dose, patients needed minimal day of surgery opioid. And then the same thing on the right is opioid equivalents in total, not just methadone, non-methadone equivalents. So the take-home message was that single dose of methadone reduced in-hospital opioid use. Now, that was interesting, but we also had patients fill out diaries when they left the hospital. And for 30 days postoperatively, they told us what their pain scores were. They told us how much opioid they used. And if you look at the panel on the left, those are pain scores. And if you compare the red dots to the black squares, what you see is that the patients who got 0.15 mg per kilo of methadone had much lower pain scores. And their pain scores went to 0 much earlier. The panel on the right is 30-day postoperative opioid use. And single intraoperative dose of methadone at induction, these patients used less opioid for 30 days postoperatively. Not much of what we do in the operating room has this kind of a knock-on effect or long-duration effect after patients leave the institution. Single dose of methadone. So we kind of now refer to methadone as an opioid-sparing opioid. We did the same study in next-day discharge surgery, same dose escalation design. Now we had more cohorts because these procedures are more painful. Again, most were women. Most of the cases were laparoscopic hysterectomies or laparoscopic hiatal hernias. The cases lasted about 3 hours, but the same sort of dosing. And we went up as high as 0.3 mg per kilo, or on average about 17 milligrams of methadone for these next-day cases. What you see here is the data on PACU opioid administration. We never could get all the way down to 0, but we decided not to push the dose beyond 0.3 mg per kilo because we didn't want to get to a maximum tolerated dose. We wanted to get to a reasonably effective dose. Panel on the right is the post-PACU day of surgery opioid use, and you see that's a lot less in the patients that got intraoperative methadone. Total day of surgery non-methadone use is shown on the left, and you can see that methadone was an opioid-sparing opioid. If we look at total hospital opioid use on the right, again, you see that the patients that got a dose of methadone used less opioid in the hospital. And this is total 30-day postoperative opioid use, and again, you see that at the higher dose of methadone, patients used a lot less take-home opioid. So again, methadone is an opioid-sparing opioid. When Glenn Murphy did his studies in cardiac surgery and major spine surgery, he queried patients for a year postoperatively to see what their pain scores were like. And what he found was that for the first 1 to 3 months postoperatively, the patients that got methadone compared to other opioids had less pain. And again, I've shown you that data on the right. So a single intraoperative dose of methadone confers long-term benefit. Another benefit is that it's inexpensive. 4 hours of a remifentanil infusion at our institution costs $340. 20 milligrams of methadone is $42. Our institution likes those numbers. I will remind you that children hurt too. Things like appendectomies, tonsillectomies, extremely painful, and we know that the pain is very undertreated. One of my colleagues at Duke did a study in children looking at methadone for pediatric tonsillectomy. Again, she did a dose escalation study. She got as far as 2 doses, 0.15 mg per kilo. PACU opioid use is shown on the left, and it dropped to pretty much 0. The panel to the right of that shows the fraction of patients needing no opioid in the PACU. At the 0.15 mg per kilo dose, it was 55% of the patients. Next panel over is 7-day postoperative take-home opioid use. And again, what you see is that the patients who got methadone used a lot less opioid. And then the panel on the right shows that if you didn't need any opioid in the PACU, your 7-day take-home opioid use was almost nil. So good postoperative pain control predicted long-term pain benefit. So her conclusion was that in children having tonsillectomies, methadone was effective, opioid-sparing, and very well tolerated. Now, some recent surveys said, well, why don't people use methadone? Well, they said a number of reasons. Well, there's no data on effectiveness. We're concerned about respiratory depression. We're concerned about QT prolongation, and there's no protocol. So hopefully I've shown you that the drug is effective. I've shown you that there is not a problem with postoperative respiratory depression. I'll show you the QT data in just a minute, and I'll give you some protocols. Now, this is a slide just to reinforce the concept that methadone is fast onset. This is a study that actually looked at pupil diameter as a way of measuring opioid onset. This was a single intravenous 10 milligram bolus of methadone, and on the left you see pupil diameter, and basically the drug onset is in the matter of a couple of minutes. Maximum effect is within 10 minutes, and the panel on the right shows you that it continues for hours after that single dose. This is a study done collaboration with MD Anderson. We looked at postoperative opioid-induced respiratory depression. There's lots of data, but I just want you to look at the two columns, methadone no or methadone yes, and the bottom line, literally and figuratively, is postoperative naloxone use, and there was no difference whether patients got methadone or other opioids in terms of the use of postoperative naloxone. I looked at this in a previous institution at 150,000 surgical patients. We asked, does the use of methadone affect PACU discharge? Does it affect postoperative nausea and vomiting? And does it affect respiratory depression? We measured PACU discharge time. We used antiemetic dosing as a surrogate for postoperative nausea and vomiting, and we used naloxone administration as a surrogate for respiratory depression. And the take-home message was that PACU discharge times were no different whether patients did or did not get methadone. Antiemetic use was no different whether patients did or did not get dosed methadone, and respiratory depression was no different either. So our conclusion was that methadone does not confer a risk as far as delayed discharge, postoperative nausea, vomiting, or respiratory depression. Methadone carries a black box warning about torsade de pointe and risk of QT prolongation. I will simply cut to the bottom line and tell you that those data came from a population where the average methadone dose was 400 milligrams. How many of you think this is relevant to the 10 or 20 milligrams that we use in the operating room? I don't. Here's a protocol. We can distill all of this down to a single slide. At the beginning of, and this is in adults, I've shown you the data, this is adults. For inpatients, 20 milligrams. Next day discharge, 15 milligrams. Same day discharge, 10 milligrams at or near induction. Like the George Foreman grill, set it and forget it. One dose of methadone in induction, have a seat. At the end of the case, patients will need a CO2 in the high 40s or low 50s in order to breathe, much the same way that when we look at patients when they leave the PACU, if they've gotten PACU opioids, they have CO2s in the high 40s or low 50s. So get the CO2 up early at the end of the case. Reverse neuromuscular blockade as soon as possible. Get patients breathing spontaneously while they're still unconscious. Statistically, most of them are going to be breathing 10 to 12 times a minute at a CO2 in the high 40s or low 50s. If for some chance they're breathing 20 times a minute, give them another couple of milligrams of methadone, get the respiratory rate down to 10 to 12, and all of these patients will wake up pain-free. In the PACU, we approach this by writing standing orders for 2 milligrams of methadone at a time, up to a maximum of 6. The reason is that we know that after those intraoperative doses and 6 of methadone in the PACU, it's unusual that patients need more. If the nurses think the patients need more, I want a phone call. I want to go see the patient in the PACU to make sure that it is not a pain problem that it needs to be treated. For example, after prostatectomies, bladder spasm is common. That's not something that should be treated with opioid. It should be treated with a different class of drugs. And then important to remember, minimize the use of sedating drugs. Sedating drugs potentiate opioid-induced respiratory depression. So I avoid sedating drugs in the perioperative period as much as possible. Gabapentinoids, for example, sedating antiemetics, postoperative antihistamines for nausea and vomiting, and postoperative benzodiazepines. So my institution asked me if I would make a one-page cheat sheet that would be available on our intranet. And this is what I put together, which is sort of the one-page take-home cheat sheet. It's in the handout. It's not copywritten. It's meant to be used for educational purposes. So to summarize, methadone is a long-duration, very low-cost alternative to providing conventional, if not better, postoperative and perioperative anti-nociception and pain control. I've shown you that it gives you better postoperative analgesia than conventional opioids. The onset is fast. It's as fast as fentanyl. It's practical. It's opioid sparing. And really, this is a paradigm shift in what we do in the operating room, getting away from the concept of shorter and shorter duration opioids to the concept of using an opioid whose duration of effect matches the duration of pain. And I will posit that this really does address some of the challenges of providing adequate, if not optimal, analgesia, reducing the risk of respiratory depression, and dealing with the whole opioid crisis and potentially decreasing the need for oral take-home opioids. So that's my story. I'm going to stick to it, and I welcome any questions you have during the discussion section. Thank you.